Hi and welcome back to another video of Medic Notes. This video is on adhesive capsulitis. Adhesive capsulitis, also known as frozen shoulder, is a condition of the shoulder characterized by functional loss of both passive and active shoulder motion. Commonly associated with diabetes and thyroid disease. Diagnosis is made clinically with marked reduction of both active and passive range of motion of the shoulder. Treatment is a prolonged course of aggressive physical therapy and medical management of underlying disease if present. Manipulation under anesthesia or arthroscopic capsular release is indicated in patients with progressive loss of motion having failed a prolonged course of physical therapy. It is more commonly seen in women 40 to 60 years old. For its mechanism of injury, it can be primary and idiopathic form, or can be post-traumatic, following proximal humerus fracture or immobilization for other upper extremity injury, and also post-surgical following rotator cuff repair or axillary dissection for malignancy. Inflammatory process causing fibroblastic proliferation of joint capsule leading to thickening, fibrosis, and adherence of the capsule to itself and humerus. Fibroblasts or myofibroblasts with abundant type 3 collagen present leads to mechanical block to motion. Essential lesion involves the coracohumeral ligament and rotator interval capsule, thus leading to adhesive capsulitis. The associated conditions are diabetes, autoimmune thyroid disorders, Dupuytren's disease, atherosclerotic disease, and cervical disc disease. It can be classified into freezing type, where there is gradual onset of diffuse pain, frozen or stiff type, where there is decreased range of motion, and thawing, where there is gradual return of motion. There are also 4 stages: Stage 1 with patchy fibrinous synovitis, Stage 2 with capsular contraction and fibrinous adhesions, Stage 3 with increasing contraction and resolving synovitis, Stage 4 with severe contraction. For its presenting symptoms, there is often insidious onset of general shoulder pain preceding any noticeable loss of motion. Variable character and severity of pain, loss of motion dependent on the stage of disease at presentation. For freezing type, there is an insidious onset of pain at rest and with movement and difficulty sleeping. For frozen type, pain lessens but significant motion limitations affecting ADL. And thawing, pain is gone and motion improves but less than normal. On inspection, note any muscle atrophy or scars denoting prior surgery. For motion, look for symmetric loss of active and passive ROM. Document all motion planes and compared to contralateral side. Limitations in motion may be slight. External rotation deficit is the most common finding. Some provocative tests like impingement, biceps, and slap maneuvers are often positive. Rotator cuff testing may be limited given loss of motion. Radiographs are the most common imaging. Recommended views are API, scapular Y, and axillary lateral. Findings are disuse osteopenia, and can look for osteoarthritis, posterior dislocation, or surgical hardware. Other investigations are MRI plus/minus arthrography. Treatment can be non-operative or operative. Non-operative treatment are physical therapy, NSAIDs or intra-articular steroid injections, heat or cryotherapy. Operative treatment include manipulation under anesthesia, and arthroscopic or open capsular release. Complications of frozen shoulder: residual stiffness, axillary nerve injury with capsular release, proximal humerus fracture, dislocation, rotator cuff tears or brachial plexopathy. For its prognosis, it is a self-limited disease, with worse outcomes among diabetics. After surgical treatment, gains in range of motion and improved function are maintained at long-term follow-ups. That's all for this video. Thank you.